Right now, your hands, before you do anything else. 10 small plates at the tips of your fingers. Most people see cosmetics, a chip, a hangnail, something to fix before a meeting. Clinicians see something entirely different. Lung cancer has announced itself on fingernails. So has liver cirrhosis. So has severe anemia. All of it, visible months before the patient felt a single symptom. In 2019, a widely shared story circulated among dermatologists about a patient who posted a photo of their nails online, domed, convex, curving over the fingertip like the face of a watch glass. The comments flooded in with reassurance. One response was different. Get to an oncologist today. The person listened. Early-stage lung cancer. Surgery. Survival. No routine blood panel had caught it. The nails caught it first. That is not coincidence. That is biology. And it raises a question you should be asking yourself right now. When was the last time you actually looked? I'm Eloan Fairley, and you're watching Dr. Eloan Fairley. If you want health information explained in plain language, verified, direct, and without the drama, subscribe and turn on notifications. We are building a channel around one principle. You deserve to understand your own body. Before we go any further, I need to destroy a myth that has been circulating for generations. White spots on your nails do not mean you are low on calcium. You have heard this. Someone told it to you as a child, pointing at a tiny white dot on your pinky. It is not true. It is completely, clinically, demonstrably false. Research published in the British Journal of Dermatology has definitively found no link between those white spots and calcium deficiency. If you have been believing the calcium myth, you have been misreading every other signal your nails send. And some of those signals are a matter of life and death. Today, we correct that. To understand why a nail is such a powerful diagnostic tool, you need to understand what it actually is, and most people have never been told. The nail plate, the hard surface you see and feel, is formed inside the matrix. The matrix is a small zone of living tissue tucked beneath the skin at the base of your finger, just under the cuticle. It is extraordinarily sensitive. Any disruption in your metabolism, any nutritional deficiency, any inflammatory process, any circulatory change shows up in what the matrix produces. The plate changes color, it changes shape, it changes texture and growth rate. It records your health history the way a flight recorder captures a journey. A full nail replacement takes between 4 and 6 months on average. That means right now, on your hands, you are carrying up to 6 months of biological history. Every ridge, every groove, every shift in color is an entry in that record. The only question is whether you know how to read it. 90% of the nail plate is made of keratin, the same structural protein that forms your hair, but the architecture is entirely different. In a nail, keratin fibers stack in layers like sheets of bonded material held together by sulfur bridges. Those bridges are what make the nail hard rather than flexible. This also means sulfur is critical to nail integrity. If your diet is consistently low in sulfur-containing foods, eggs, garlic, cruciferous vegetables, the layers begin to separate. Splitting and peeling are the visible surface signs, but the mechanism underneath can point to something far more significant than a dietary gap. Between those keratin layers sit microscopic films of fat and water. They are what give a healthy nail its faint gloss and smooth feel. When the body is chronically dehydrated, and as we age, the brain's thirst signaling becomes less reliable, meaning people routinely drink less than they need without realizing it. Those films thin out. The surface turns dull. Microcracks develop. Flexibility decreases. Most people blame the weather or hand washing. The actual cause is often sitting in a glass they are not filling often enough. Beneath the nail plate lies the nail bed, thin tissue threaded through with capillaries. Blood shows through it, giving a healthy nail its characteristic pinkish tone. The composition of that blood is visible right there on your fingertip. Hemoglobin drops and the pink fades toward white. Oxygen falls and blue-gray creeps in. Bilirubin rises, the breakdown product of red blood cells that accumulates when the liver struggles to clear it, and yellow appears. 10 small screens at the ends of your fingers, broadcasting your body's internal state in real time. Most nail changes do not happen overnight. They develop gradually, over weeks and months, and because the changes are slow, most people normalize them. They assume a dull nail is just dry skin. A thickening toenail is just age. A pale plate is just winter. By the time the change is dramatic enough to worry about, the underlying process has often been running unchecked for a long time. Understanding who is most at risk helps frame what to watch for. Age is the most consistent risk factor for nearly every nail-related condition. After 40, the nail matrix begins producing keratin less evenly. After 60, nail growth rate declines measurably and structural changes accelerate. Vascular supply to the peripheral tissues decreases. The nails become thinner, more brittle, slower growing, and more susceptible to fungal colonization. People with diabetes or impaired glucose metabolism carry a compounded risk. Elevated blood sugar impairs immune function, reduces circulation to the extremities, and creates an environment in which fungal organisms thrive. What looks like a cosmetic fungal problem in a diabetic patient is a genuine medical concern, because any breach in skin integrity in a poorly perfused foot becomes a potential entry point for bacterial infection. The consequences of ignoring it can be severe. Occupation matters significantly. People whose hands spend extended time in water, cooks, healthcare workers, cleaners, bartenders have a substantially elevated risk for fungal and bacterial nail infections. Exposure to harsh chemicals without gloves accelerates structural breakdown over years. And people who use acetone-based nail products daily or alcohol-based sanitizer many times a day over years are systematically stripping the nail of moisture and integrity. Nutritional status is an underappreciated risk factor in developed countries, where malnutrition is assumed to be absent. Subclinical deficiencies. Iron, zinc, B vitamins, fat-soluble vitamins, adequate protein are surprisingly common and show up in the nails before they show up in standard blood panels. The nails are peripheral tissue. They are among the first places the body reduces resources when internal supplies run short. The reason most people miss early nail signals is straightforward. They are not looking. Not systematically, not in good light, not with the intention of comparing what they see today to what they saw last month. The information is there. The habit of reading it is simply not taught. Color is the first dimension of nail assessment and the one that carries the most immediate clinical information. A healthy nail plate is pink, evenly pink from the base to just before the free edge, with a pale crescent at the base and a clear white edge at the tip. Any deviation from this pattern is a message. Learning to read those messages requires knowing what each color change means. Yellow nails are the most common complaint. The first cause is fungal infection, onychomycosis, in which organisms penetrate beneath the free edge, break down keratin, and alter the color, texture, and thickness of the plate. Most people shrug off a fungal nail. It looks cosmetically unpleasant, but surely it is not dangerous. This is a mistake, and the stakes are higher than most people realize. Fungal infection is an open door. In people with impaired glucose metabolism, elevated blood sugar, whether diagnosed or not, what appears to be a minor cosmetic problem can cascade. Any break in the nail barrier creates an entry point, and in a foot with reduced circulation and compromised immune response, bacteria can reach tissue that has no capacity to mount an effective defense. The CDC reports approximately 130,000 to 150,000 lower limb amputations annually in diabetic patients in the United States, with skin and nail integrity failures among the contributing entry point factors. A fungal nail is not minor if you have blood sugar issues. The second cause of yellow nails is systemic. Yellow nail syndrome involves all 20 nails simultaneously turning yellow, thickening dramatically, growing extremely slowly, and the cuticle nearly disappearing. At the same time, the patient develops swelling in the lower limbs and chronic respiratory complications. The underlying mechanism is failure of lymphatic drainage, the body's network for removing excess fluid and metabolic waste from tissues. When it breaks down, airways suffer, peripheral tissues swell, and growth zones fail. Yellow nail syndrome is not a cosmetic finding. It is a manifestation of systemic lymphatic dysfunction. Blue, gray, or violet nails result from reduced blood oxygen saturation. When hemoglobin is not carrying enough oxygen, it darkens, and that darkness shows through the thin tissue of the nail bed. Blue nails are a classic sign of tissue oxygen starvation. Causes include chronic obstructive pulmonary disease, severe asthma, congenital heart defects, and severe anemia. Certain antiarrhythmic medications used to control heart rhythm can produce the same effect. If you are taking antiarrhythmics and notice bluish discoloration, contact your doctor without waiting for your next scheduled visit. We have already established that isolated white spots are benign, the result of minor trauma to the matrix. But not all white findings on nails are harmless, and the distinction between them is clinically critical. Horizontal white bands running completely across the nail appearing on multiple fingers simultaneously are a fundamentally different finding. These are called Mises lines, described by a 19th century Italian physician and documented extensively since. They appear when the matrix is disrupted not by a single local trauma, but by a systemic event. Mises lines are associated with heavy metal poisoning, chronic kidney disease, and severe protein deficiency. The difference between a small white dot and a full transverse white band is the difference between a scuffed bumper and a cracked engine block. Similar in superficial appearance, completely different in significance. If the entire nail plate has turned uniformly white, milky, opaque with no pink showing through, this finding, known clinically as Terry's nails, is associated with serious liver dysfunction. When the liver is failing, specific proteins accumulate in the blood and the vascular pattern beneath the nail plate changes. The pink disappears. In clinical literature, this is described as one of the classic early signs of hepatic cirrhosis, appearing before jaundice develops, before abdominal pain begins. The nail signals first. Now, the most important color finding in this entire video. A dark longitudinal stripe, a narrow brown or black line running from the base of the nail to the free edge appears on a single finger. In people with darker skin tones, this is often completely normal, representing activation of pigment-producing cells in the matrix. But there is an aggressive form of skin cancer that develops specifically beneath the nail plate, acral lentiginous melanoma. It is dangerous precisely because it can masquerade as a harmless pigment streak for an extended period. The warning signs that should send you to a dermatologist immediately, not next week, today, are these. The stripe is wider than 3 millimeters. The edges are blurred rather than sharp. The color is uneven within the stripe. The pigment has spread beyond the nail onto the surrounding skin of the finger itself. Any one of these features demands immediate evaluation by a dermatologist. Early detection is the difference between a manageable condition and a life-threatening one. Color is half the picture, shape is the other half, and changes in nail shape can be specific enough that an experienced clinician begins forming a differential diagnosis from across the room. Place your hand flat on a surface and look at your nails from the side. A healthy nail has a gentle, shallow outward arch, the curve of a relaxed structure. If instead you see a concavity, a dip in the center as though the nail has been pressed inward like a tiny spoon, that is called koilonychia, and it almost always signals a significant iron deficiency. Iron is directly involved in the biochemical process of building keratin. When iron is insufficient, the fibers do not stack with the correct structural integrity, and instead of an arch, the nail develops a hollow. What makes this clinically remarkable is that koilonychia can appear before iron deficiency registers on a standard blood test. The body prioritizes maintaining hemoglobin levels by redistributing iron reserves, but peripheral tissues, including the nail matrix, are starved first. Your fingers detect the deficiency before the laboratory does. Koilonychia also develops in people with years of unprotected exposure to harsh chemicals, bleach-based cleaners, industrial solvents, strong acids. These agents break down the sulfur bridges holding keratin layers together. The nail loses its rigidity and begins to buckle inward. Gloves are not optional for people who work regularly with these substances. After 5 to 7 years of unprotected exposure, the structural damage becomes irreversible. Now the opposite finding, a nail that is excessively convex, domed, rounded like the face of a watch, attached to a fingertip that is itself thickened and enlarged. This is clubbing, or Hippocratic fingers, described by Hippocrates over 2,500 years ago and still clinically significant today. In specific pulmonary and cardiac diseases, substances are released into the bloodstream that stimulate growth of soft tissue around the distal phalanges, the joints at the very tips of the fingers. Capillaries expand, connective tissue swells, the fingertip thickens, the nail curves over it. The conditions associated with clubbing include lung cancer in approximately 35% of cases, pulmonary fibrosis, empyema, congenital heart defects, cirrhosis, and inflammatory bowel disease. Every item on that list is a serious condition. You can screen for clubbing at home right now. Press the nails of matching fingers together, nail to nail, same finger, both hands. If you see a small diamond-shaped gap between the bases of the two nails, that is normal. If the nails press flush with no gap at all, that warrants a medical consultation. This is called Shamroth's sign. It takes 3 seconds and requires nothing but your own hands. Every signal described in this video operates on a timeline. A dark stripe that appears this week will not wait indefinitely for you to decide whether it matters. A fungal infection in a diabetic foot, left untreated, does not stay a fungal infection. Clubbing that signals early-stage pulmonary disease represents a window, a period in which intervention changes outcomes. Once that window closes, the options narrow. The concept of a diagnostic window is not dramatic language. It is a clinical reality. Acrolentigenous melanoma, detected at an early localized stage, has a 5-year survival rate substantially above 80%. Detected after it has spread to lymph nodes or distant tissue, that rate drops dramatically. The nail changes that signal it may be visible for months before the diagnosis is made, if anyone looks. Liver cirrhosis follows a similar pattern. Terry's nails and other hepatic nail signs can appear during compensated cirrhosis, when the liver is still functioning adequately despite significant scarring. At this stage, intervention, whether lifestyle changes, treatment of underlying hepatitis, or management of contributing factors, can slow or halt progression. Once decompensation occurs, options become more limited. The same logic applies to iron deficiency indicated by koilonychia, to hypothyroidism signaled by brittle nails, to the early autoimmune processes flagged by nail pitting. These are conditions with excellent treatment outcomes when identified at the stage the nails are flagging. Waiting until other symptoms appear means the condition has already progressed. If you have observed any of the warning signs described in this video, a dark stripe, complete white nailing, clubbing without a known cause, persistent yellow nailing, blue discoloration not explained by cold, the appropriate response is not to monitor for another 6 months. The appropriate response is to contact your physician this week and describe specifically what you have observed. Bring a photograph. The information is actionable right now. Understanding the surface signs is only useful if you understand the biological mechanisms driving them. The nails are not generating these changes arbitrarily. They are the output of processes happening deep inside the body, in the liver, the thyroid, the bone marrow, the blood vessels, the immune system. The nail is the readout. The problem is elsewhere. Iron deficiency, which produces koilonychia, operates through the interruption of keratin synthesis at the cellular level. Iron is a cofactor in multiple enzymatic reactions involved in protein production. Without adequate iron, the matrix cells cannot produce keratin with normal structural properties. But iron deficiency itself has causes that extend far beyond diet. Poor absorption from the gut, chronic blood loss, including from the gastrointestinal tract, where small bleeds can be silent for years, increased demand during pregnancy, and certain medications that affect stomach acid production are all common contributors. The spoon nail is a downstream indicator of an upstream problem that may be entirely invisible otherwise. Hypothyroidism, which causes brittle, slow-growing, thickened nails, operates through the thyroid gland's role as the metabolic regulator of every cell in the body. Thyroid hormones control the rate of cellular activity in the nail matrix, in the skin, in the hair follicles, in the heart. When thyroid output falls, everything slows. Nail production becomes irregular. The keratin produced is structurally weaker. Growth slows measurably. Because hypothyroidism is gradual, patients often normalize the changes. They move more slowly, feel colder, gain weight, and grow brittle nails, attributing each change to age rather than to a single treatable hormonal deficiency. A simple TSH blood test can identify it. Treatment is straightforward. The nails were pointing at it the whole time. The biological mechanism behind clubbing remains an area of active research, but the current understanding involves platelet-derived growth factor and other vascular mediators. In conditions where oxygen delivery to peripheral tissues is chronically impaired, or where tumors produce specific signaling molecules, these mediators stimulate abnormal growth of the soft tissue and vasculature. At the fingertips, the nail curves over the enlarged tissue. It is the body's circulatory system communicating its dysfunction through the one tissue thin enough to make the signal visible. A single risk factor rarely tells the whole story. The real danger is when multiple contributing processes overlap, and this is exactly where standard medical appointments fall short. A routine annual checkup in most healthcare systems does not include a systematic nail examination. There is no standard protocol for it. Physicians are time-limited, focused on the chief complaint, reviewing laboratory values from the last visit. The nails are not on the checklist. This is not negligence. It is a structural limitation of how medicine is currently practiced. The implication is that nail-based diagnostic signals fall into a gap between what the system is designed to catch and what the body is actually communicating. The compounding effect of multiple risk factors is the most underappreciated danger in preventive health. Consider someone in their late 50s with subclinical hypothyroidism, thyroid function at the lower end of normal but not yet flagged as abnormal. Add mild iron deficiency from a diet that has shifted away from red meat. Add chronic dehydration from an aging thirst mechanism. Add daily exposure to alcohol-based sanitizer from a healthcare role. Each factor alone produces a modest nail change. Together, they produce brittle, slow-growing, pale, structurally compromised nails that collectively point to a systemic picture no single blood test would capture without knowing what to look for. The nail findings tell the clinician which panels to order. Brittle nails plus pale plate plus slow growth plus dry skin, that is a thyroid plus iron workup. Nail pitting plus joint stiffness in the small fingers, that is a psoriatic arthritis investigation. Clubbing in a 50-year-old smoker, that is a chest imaging referral. The nails do not make the diagnosis, they direct the investigation, but only if someone is reading them. The practical implication is that you need to be the person who reads them because no one else has the time or the incentive to do it on your behalf on a regular basis. What you observe and bring to your clinician shapes what they investigate. The more specific your observation, the more useful the clinical encounter. If you have identified any of the warning signs described in this video during the time you have been watching, the following steps apply. This is not a list of things to eventually consider. These are actions with time-sensitive relevance. If you have observed a dark longitudinal stripe on any nail, particularly with blurred edges, with greater than 3 mm, uneven color, or pigment spreading onto surrounding skin, contact a dermatologist this week. Not a general practitioner first, not after a Google search, a dermatologist. Describe specifically what you see and ask for an urgent appointment. Bring a photograph of the nail taken in natural daylight. If you have observed complete white opacification of multiple nail plates, milky pink-free, contact your primary care physician and ask for liver function tests, specifically ALT, AST, GGT, bilirubin, and albumin. Mention that you are concerned about hepatic function and that you have observed nail changes consistent with Terry's nails. Using that specific clinical term will communicate to your physician that you have done research and know what you are describing. If you have observed clubbing confirmed by Shamroth's sign, contact your physician and ask for a chest X-ray and pulmonary function assessment. If you are a current or former smoker, make that explicit. Do not frame this as, I think something might be wrong with my nails. Frame it as, I have detected possible nail clubbing confirmed by Shamroth's test, and I want to rule out pulmonary or cardiac pathology. If you have observed spoon nails or significant pallor across the nail plates, ask for a complete blood count and serum ferritin. Serum ferritin is more sensitive for iron stores than standard hemoglobin testing and can detect deficiency earlier. Ask specifically for ferritin, not just hemoglobin. If you are a diabetic patient or have elevated blood sugar and you have any fungal nail infection on your feet, any yellowing, thickening, crumbling of toenails, do not treat this as cosmetic. Contact your endocrinologist or primary care physician and request a referral to a podiatrist. This is a medical issue. Do not self-medicate any of these findings. Over-the-counter antifungal treatments may mask a more serious process. Vitamin supplementation without testing can interfere with accurate diagnosis. Get the right information first, then treat with guidance. Based on the nail findings described in this video, 3 specific clinical tests provide the most diagnostically valuable information. Know their names, understand what they show, and use precise language when speaking to your physician. Test 1. Serum ferritin. Ferritin is the storage protein for iron in the body. Standard blood panels check hemoglobin, which reflects the amount of iron currently in circulation. But hemoglobin is a lagging indicator. The body maintains hemoglobin levels by drawing down its iron stores, so hemoglobin can appear normal while ferritin, reflecting actual reserves, has already fallen significantly. Serum ferritin is the early warning indicator that hemoglobin is not. Normal ferritin in adults is generally considered to be between 12 and 300 nanograms per milliliter, with levels below 30 commonly associated with symptoms even when hemoglobin remains technically normal. If you have spoon nails, pale nail plates, chronic fatigue, or hair thinning, ask specifically for serum ferritin. The word to use with your doctor is ferritin, not just iron levels. Test 2. Thyroid-stimulating hormone, TSH, with free T4-TSH, is the pituitary hormone that signals the thyroid to produce its hormones. When thyroid output falls, TSH rises as the pituitary tries to compensate. A standard TSH test will detect overt hypothyroidism, but in subclinical hypothyroidism, early-stage dysfunction that produces real symptoms including brittle nails, fatigue, weight gain, and cold intolerance, TSH may be at the upper end of the normal range rather than clearly elevated. Requesting TSH together with free T4, the active thyroid hormone itself, gives a more complete picture. If you have brittle, slow-growing nails with any of the associated symptoms, ask for a full thyroid panel, TSH plus free T4. Test 3. Nail fold capillaroscopy. This test is less widely known but increasingly available through rheumatology and dermatology departments. A clinician examines the small blood vessels at the base of the nail fold capillaries, under magnification. In healthy individuals, these capillaries form neat, regular loops. In systemic autoimmune diseases, scleroderma, lupus, polymyositis, dermatomyositis, the capillaries dilate, deform, and in some areas disappear entirely. This test can detect autoimmune vascular disease at its earliest stages, before joint symptoms, before skin changes, before other laboratory markers have shifted. If you have chronic nail fold redness, cuticle inflammation across multiple fingers, or any combination of joint pain and nail changes, ask your rheumatologist specifically about nail fold capillaroscopy. Prevention in the context of nail health means two things simultaneously: protecting the nail structure itself, and using the nails as an early detection system to identify systemic conditions before they advance. Both are within your control. Nutritional foundations. The nail matrix requires adequate iron, zinc, biotin, sulfur-containing amino acids found in eggs, legumes, and cruciferous vegetables, and fat-soluble vitamins for normal keratin production. The critical point is that supplementation without testing is not prevention, it is guesswork that can distort future blood results. Get a baseline blood panel that includes ferritin, TSH, free T4, zinc, and a complete blood count. Then address what is actually deficient, not what is fashionable to supplement. Hydration as a clinical priority. Chronic low-grade dehydration is one of the most underappreciated contributors to nail brittleness, skin fragility, and reduced matrix function in adults over 40. The brain's thirst signaling becomes less responsive with age. Research published in the Journal of Gerontology has documented this consistently. Waiting until you feel thirsty means you are already behind. A target of 50 to 60 ounces of water daily, approximately 1.5 liters as a minimum, adjusted upward in hot conditions or with physical activity, is supported by available evidence. This is not a dramatic intervention. It is a physiological baseline. Chemical exposure reduction. If you use acetone-based nail products, alcohol sanitizers more than 3 times daily, or work with bleach-based cleaners or industrial chemicals without gloves, you are systematically degrading nail integrity. Replacing acetone removers with acetone-free alternatives, using barrier cream before cleaning product exposure, and wearing nitrile gloves for chemical handling are small habit changes with measurable impact over time. Monthly systematic examination. This is the most important preventive action. A 5-minute monthly nail examination in natural light, with nail polish removed, examining color, lunulae, surface texture, shape, structural integrity, the perimeter skin, and the toenails, followed by a photograph for comparison, is a genuine early detection protocol. The systems designed to keep you healthy depend on you showing up with a problem. This examination helps you identify the problem before it develops into a presentation that requires emergency management. Your age is not a passive number. It is an active biological variable that changes how your nails form, how fast they grow, how they respond to deficiencies, and what diseases they are most likely to be signaling. In your 20s and 30s, nail changes are most commonly nutritional or mechanical. Iron deficiency from inadequate diet or heavy menstrual bleeding is the most common cause of koinonia in this age group. Nail pitting emerging in early adulthood is often the first clinical sign of psoriasis, which frequently presents between ages 15 and 35. Trauma-related leukemia from physical activity, sports, or occupational hazards is common and benign. The most important action in this decade is to establish baseline knowledge of what your nails normally look like so that future changes are recognizable. In your 40s, the pattern shifts. The thyroid dysfunction becomes more prevalent, particularly in women, where autoimmune hypothyroidism, Hashimoto's thyroiditis, has a peak onset in the 4th and 5th decades. Brittle nails, slowed growth, and coarsening of the nail surface warrant a thyroid panel in this age group rather than automatic attribution to aging. Blood sugar abnormalities also begin to emerge in this decade for many people. Their impact on nail and skin integrity is often underappreciated until complications develop. After 50, vascular health becomes the dominant factor in nail presentation. Toenail thickening, slowed growth, recurrent fungal infections, and capillary refill time extending beyond 2 seconds are all markers of declining peripheral circulation. This is the decade in which addressing cardiovascular risk factors, blood pressure, blood lipids, blood sugar, smoking cessation, has the most direct impact on peripheral tissue health, including nail health. The nails at this point are a circulation gauge. After 65, the compounding of all the above factors accelerates. Nail growth rate has declined by roughly half compared to young adulthood. Matrix activity is reduced. Vascular supply is more limited. Nutritional absorption from the gut has decreased across multiple pathways. Any change in nail appearance that is new, not the gradual change of years, but a change over months, deserves clinical attention rather than age attribution. The academic literature on nail diagnostics is more extensive than most patients, and many clinicians realize it is also more practically applicable than it tends to be presented. Research published in the Journal of the American Academy of Dermatology has consistently documented that nail clubbing, when identified in a non-smoker with no known cardiac or pulmonary history, prompts chest imaging that identifies previously unknown pathology in a clinically meaningful proportion of cases. The nail was the only presenting sign. Studies in rheumatology have demonstrated that nail fold capillaroscopy, when applied to patients with early undifferentiated connective tissue disease, accelerates diagnosis of scleroderma by an average of 2 to 4 years compared to waiting for additional clinical criteria to manifest. 2 to 4 years of earlier treatment from a test that examines the base of your fingernail. Iron deficiency research has established that serum ferritin below 30 nanograms per milliliter is associated with symptoms including nail changes, fatigue, hair thinning, and reduced cognitive function, even when hemoglobin is within the normal reference range. This means a significant number of people are experiencing real physiological effects of low iron while being told their blood results are normal, because the wrong measure was checked. The research has been available for over a decade. The clinical practice has been slower to incorporate it. The relationship between nail pitting and psoriatic arthritis is particularly well documented. Studies published in the Annals of the Rheumatic Diseases have shown that patients with psoriasis who have nail involvement, pitting, onycholysis, nail thickening are at substantially higher risk for psoriatic arthritis than those with skin involvement alone. Nail examination in psoriasis patients is now considered a standard component of rheumatological assessment precisely because of this evidence. What the research collectively shows is that the nail examination is not an alternative medicine technique. It is a validated, evidence-supported clinical assessment that happens to require no equipment, no appointment, and no laboratory cost. It has simply not been integrated into routine preventive care in a systematic way. Everything we have covered today comes down to one central truth. Your body is continuously generating information about its internal state, and your nails are one of the most accessible windows into that information. The signals are there, the knowledge to read them is now in your hands, literally. Here is your 3-step action plan for this week. Step 1. This week, perform a full nail examination. Remove all nail polish. Use natural daylight or a bright lamp. Examine both hands and both feet. Check color, any yellow, white, blue, gray, pale, or dark streaks. Check shape, any spoon-like concavity, excessive doming, or widening of the fingertip. Check surface, ridges, grooves, pitting. Check the nail border, any chronic redness, swelling, or inflammation. Check the lunulae, are they visible on your thumbs? Photograph what you see. Step 2. If you observed anything that corresponds to the warning signs in this video, book a physician appointment this week. Use the specific clinical language you have learned: Koilani-Che, Terry's nails, Mises lines, Shamroth sign, onycholysis. Request the specific tests, serum ferritin, TSH with free T4, and if relevant, liver function tests, or a referral for nail fold capillaroscopy. The more precise your language, the more focused the clinical response. Step 3. Establish a monthly nail examination habit. 5 minutes, natural light, both hands and feet. A photograph stored in your phone. Over 6 months, you will have a visual timeline that is more informative than most things that happen in an annual checkup. To close with the fact we opened with, a photograph of nails was shared online. One person in the comments recognized clubbing. One person listened. Early-stage lung cancer was caught before symptoms appeared. The nails caught it first. That outcome is not luck, it is biology, and now it is knowledge you carry. The body gave you a continuous diagnostic instrument that runs without batteries, without a subscription, and without an appointment. It is working right now at the ends of your hands. Use it. Always consult a qualified healthcare professional regarding any health concerns. This content is for educational purposes only and does not constitute medical advice, diagnosis, or treatment. If this video gave you information that could protect your health or someone you love, subscribe to Dr. Elowen Fairley. Share this, it could save a life. And leave a comment telling us which warning signs surprised you most.